Preventing perineal tears and incontinence in pregnancy. This podcast was created by Alice McLaren and Jess Mearson. Alice and Jess are both second-year midwifery students at Federation Uni in Ballarat, and Alice currently works at Southwest Healthcare in Warrnambool, and Jess is working at East Grampians Health Services in Ararat. So what is a perineal tear? Perineal tear is when the skin and all the muscles in the perineum, the vagina and the anus are injured during birth. There are different types of perineal tears, and they're classified as being first, second, third or fourth degree, depending on the area that has been affected. Sometimes when you're in labour, doctors may suggest to have an episiotomy, which is where they will cut part of the muscle to reduce the likeliness of serious perineal trauma when giving birth. And this is just a way of the tear being sutured is more easily sutured being an episiotomy rather than a serious perineal tear, which is a better option. Tears are quite common in pregnancy, especially first and second degree tears. Third and fourth degree tears aren't so common, and they say that usually about 3 in 100 women will suffer from a third or fourth degree tear in a normal vaginal birth. So a first degree tear involves the perineal skin only, and it's a thin tear in and around the vagina. Majority of women, or I should say probably half of women, will have a first degree tear recover on its own without requiring suturing, and then the other half of women may need some sutures just to help with the recovery of the tear. So you can see in this photo here how it's just the perineal skin only. So a second degree tear involves the skin and muscles in and around the vagina and the perineum, but does not affect the anal muscles. Most women who have a second degree tear have stitches to repair it, and a second degree tear can take around 2 weeks to 2 months for the skin and muscles to recover. So a third degree tear can be classified into different categories. A third degree tear involves anal sphincter complex, and we classify a third degree tear, a 3A tear, where 50% of the external anal sphincter is torn. 3B is more than 50% of the anal sphincter is torn, and 3C, the internal and external anal sphincter is torn. And you can see in the photo here just how it's a bit deeper down than the first and second degree tears, heading down towards the anal sphincter area. A fourth degree tear is injury to the perineum involving the anal sphincter complex, so external and internal, and the anal epithelium. A fourth degree tear involves a separation of the skin and muscles from the vagina through to the anus. These sort of tears, a third and fourth degree tear, usually needs to be repaired in theatre. There's strong evidence to suggest that the use of warm compresses in labour during the second stage of labour have significant effect on reducing perineal tears. So this involves holding a warm compress to the perineum during and in between contractions. Usually the midwife, with the woman's consent, is the one that holds the peripad there, but if the woman agrees to do it herself or is capable of doing it herself, it's also suggested. And it's also suggested that the water that the peripad's been in is tested on the woman before applying it to reduce the risk of burning the perineum. Perineal massage is another way of preventing resistance, which enables the perineum to stretch. So there's evidence to say that perineal massage can be performed after 35 weeks gestation, and for approximately 10 minutes at a time, and on a daily basis. And this can be performed by the woman, or if her partner would like to assist. And obviously, in labour, midwives can also attempt perineal massage. So it just involves the woman or her partner or the midwife to insert the fingers 3 to 5 centimetres into the vagina, and firmly sweep down in a downwards and sidewards motion using a natural oil or lubrication. There are some recommended. If there's any sort of incontinence cervix, if there's any signs of placenta previa or a low-lying placenta, or any signs of bleeding from the vagina in the second half of the pregnancy, it's also not recommended. If there's any signs of preterm labour, or if there's any symptoms of preeclampsia or concerns with the growth of the baby, and also if there's any vaginal herpes thrush or any other vaginal infections, obviously the massaging can spread this infection, so it's also not recommended. So sometimes the position of labour can have an impact on reducing perineal tears. There is conflicting evidence to suggest which position is the best way to reduce perineum tears or trauma. But there is one study to suggest that the lateral position will reduce the likeliness of tearing, and also the all fours position is also meant to reduce the risk of tearing. And also this position gives the woman more control of birthing the baby in that position. And women who have had an epidural have higher rates of perineal tears as they're unable to change positions. So the hands-on technique increases the flexion to reduce the presenting diameter of the baby, which therefore potentially can minimise trauma to the perineum. There is conflicting evidence as to whether the hands-on technique or the hands-off technique actually does impact on tearing, but the hands-on technique has proven to show a bit more guidance and support to bringing the baby's head down and through the birth canal. Communication between the woman and the midwife in labour, which is also called coaching, has proven to reduce the likeliness of tearing. One way of doing is when the midwife's encouraging the woman to breathe the baby's head through rather than actually pushing, just a more controlled way of birthing that head. There are some issues with communication though in women who don't speak the same language as the midwife. In this situation, women should always be given the option to have a support person who can guide them through this part, or an interpreter who does speak the same language as them. There are a few factors which impact on perineal trauma or tears in labour. The first being nulliparity. So if a woman's never had a baby before, they are at risk of tearing. Birth weight greater than 4,000 grams. Prolonged second stage of labour, so labour greater than 1 hour. Malposition of the baby. So if the presenting part's it's not the right presenting part, it will put the woman at risk of tearing. due to a larger diameter. Ethnicity, so women of Asian descent are at greater risk of tearing due to their shorter perineum. Physical inactivity before pregnancy, shoulder dystocia, instrumental deliveries, genital infibulation, and anyone that's had previous tears is at risk of tearing again. Doctors usually recommend that women who have had severe third or fourth degree tears should be recommended to have a cesarean section next baby, just to prevent the risk of this happening again. As previously mentioned, minor tears or grazes may heal themselves. Some first and second degree tears may require suturing. Third and fourth degree tears are required to be sutured / repaired in theatre. And majority of sutures utilised today for perineal suturing are dissolvable, so women don't usually have to worry about going back to get the sutures removed. They just dissolve within a couple of weeks. So there's a few things that can be done to assist in the recovery of a perineal tear or perineal trauma. And the first one of them is teaching the woman or encouraging her to perform pelvic floor exercises. Pelvic floor exercises, which Alice will talk about in a moment. The other thing is referral to appropriate multidisciplinary teams, such as the continence nurse and physiotherapist. Perineal tears can lead to incontinence, so it's important that we put these services in place to help with the recovery. Analgesia, ice, so we can put ice into peri pads just to help with the inflammation. We also want to encourage good hygiene, so ensuring the woman has a bath or a shower at least once a day, and changing sanitary pads regularly and washing hands both before and after doing so. The other thing is ensuring regular appearance to keep the bowels soft, and good support. It's not easy having a newborn baby as well as recovering from a perineal tear. So after a woman has a perineal tear, it's really important that we encourage a high fibre diet, which includes lots of fruit and vegetables, which will help promote the wound healing. Drinking lots of water, around 2 litres a day, and using sachets such as Ural, which will help the stinging when urinating, and also aperients, which I've also mentioned, to help keep those bowels soft and reduce any straining if possible. There are obviously going to be some complications after developing a perineal tear in labour. The first of those being it may lead to urinary and fecal incontinence. Alice will go into details about this in a moment. Can also lead to painful sexual intercourse, which can have a bit of strain on women down the track. It is recommended that women try to avoid having sexual intercourse for about 6 weeks after developing a perineal tear, but it's mainly just when they feel comfortable to go back to that. Women also lose self-confidence depending on how severe the tear is, whether they develop urinary incontinence or fecal incontinence, to actually go out of the house and perform daily activities that they were doing before falling pregnant. Can also lead to relationship issues at times, and they say that between 5 and 7 in 100 women who have had third or fourth degree tears will have similar tears in a future pregnancy, which is also a complication, which can be quite fearful for some women.
types of incontinence. Fecal. Inability to control your bowel movements, resulting in involuntary loss of stool or gas. Whilst fecal incontinence isn't as common as urinary incontinence, affecting around 5% of postpartum women, it's still a large issue. Often a result of third and fourth degree perineal tears, fecal incontinence causes great concern to many women. So how can we reduce the incidence of incontinence in pregnancy and the postpartum period? The pelvic floor, what is it? The pelvic floor consists of an array of muscles and ligaments that support the pelvic organs. These organs including the vagina, uterus, ovaries, bladder and rectum. The pelvic floor muscles form a sling that can be seen on the diagram to your right, like structure that sit at the bottom of the pelvis. Pelvic floor muscles stretch from the coccyx at the back to the pubic bone at the front. The pelvic floor muscles have openings or holes for passages, predominantly urine and feces, to pass through. These three holes in the female anatomy include the urethra, vagina, and anus. The pelvic floor muscles wrap firmly around these holes to keep them shut when necessary. The pelvic floor function prevents organs prolapse by supporting the pelvic organs, being the vagina, urethra, ovaries, bladder, and rectum, and keeping them in place. The pelvic floor helps facilitate childbirth. It maintains urinary and fecal continence and works in conjunction with abdominal muscles to assist in maintaining intra-abdominal pressure during events such as sneezing, coughing, laughing, and vomiting, essentially so we don't wet ourselves. It assists in defecation avoiding, and the pelvic floor also aids us in sexual function. In women, the ability to tighten the pelvic floor muscles can contribute to sexual sensation and arousal. The pelvic floor provides us with support for a baby during pregnancy and birth. The pelvic floor muscles also work in conjunction with muscles of the back and abdomen to help support our spine. So what causes incontinence? In the general population, incontinence can be caused by the following: being overweight, growing older, persistent heavy lifting, excessive coughing causing straining, constipation, which often makes us strain further, menopause, particularly our changing hormone levels. Causes of incontinence in pregnancy. During pregnancy, the hormone relaxin is released into women's bodies to help loosen up joints, ligaments, and muscles of the pelvis and allow for expansion in preparation for childbirth. This hormone release is relaxing and preparing the pelvis for childbirth and the descent of the baby into and through the pelvis. The ligaments and muscles of the pelvic floor are also loosened in this preparation phase and weaken the pelvic floor. This can cause some urinary incontinence for pregnant women. A woman's age and weight during pregnancy can also increase her risk of incontinence. Causes of incontinence in the intrapartum phase. The birth of a baby, particularly a large baby. The stretching and expansion that occurs during childbirth can consequently stretch and weaken the muscles and ligaments of the pelvic floor. Prolonged pushing and the strain this causes can also weaken pelvic floor muscles. Instrumental deliveries can weaken them, and third and fourth degree tears also. How to improve the pelvic floor muscles and prevent incontinence? Physical activity. Being physically active is highly recommended due to its links to improving pelvic floor strength. Strength promoting exercises, along with yoga and core exercises, are said to be particularly beneficial as they often engage the pelvic floor muscles. Gentle forms of exercise, like walking and swimming, can also help strengthen your pelvic floor. Eating a healthy diet that's full of fibre and prevents constipation and consequent straining is also beneficial. Drinking plenty of water, ceasing smoking, as smoking can often result in coughing that may weaken pelvic floor. Practice good toilet habits. When you need to go to the toilet and have the urge to urinate or defecate, go. This will help you avoid constipation. But the best way to reduce the risk of incontinence during pregnancy and in the postpartum period is to perform regular pelvic floor exercises. The best treatment and prevention of incontinence is to do pelvic floor exercises. Use a pelvic floor app. When you stop at traffic lights, do a round of exercises. Make a sign or a symbol at home that prompts you to do these exercises. How to perform pelvic floor exercises. Option 1. Step 1. Get comfortable. Pelvic floor exercises can be completed in a number of different positions, from sitting or standing, nice and tall, shoulders back. You could be lying down with knees bent and legs apart in a relaxed position, or kneeling on hands and knees. Step 2. Relax and focus. Try and relax. Close your eyes. Think about what muscles you would use if you're busting for the toilet and you needed to stop yourself from urinating, defecating, or passing wind. You should feel these muscles tighten. As a physiotherapist or ask a physiotherapist or continence nurse for further assistance if needed. Step 3. Squeeze and engage those muscles from your front passage, vagina, and back passage as strongly as you can for 3 to 8 seconds, but no more than 10 seconds. Repeat up to 10 times. This equals 1 set. So it's all about the squeeze and the lift. Try for 3 sets a day in various positions every day for the rest of your life. How to perform pelvic floor exercises. Option 2. This pelvic floor exercise involves a quick squeeze and release of the muscles. As strongly and as quickly as possible, squeeze, lift, and release the muscles. Rest for a few seconds in between each squeeze before repeating. Aim for 10 to 20 squeezes per set and to complete 3 sets per day. Some handy hints for completing pelvic floor exercises. Ensure you feel your pelvic muscles lift up with each squeeze. Get into a comfortable position and environment. Relax your thighs and buttocks. Stop the exercise when the muscles are fatigued and breathe normally. Treatment and management, urinary incontinence. My midwife